Welcome, everybody, to a Thursday Night Live webinar. If you are a member, you are watching this on a Friday. That is the perk that our members get. They can join some of these great talks that we have more than once a week. So we have today Dr. Lauren Keller, and I am pleased to be able to present her. She's going to be speaking to us on the topic of airway all the way to the pelvic floor and untying the connections. So Dr. Lauren Keller is a highly skilled chiropractor with a passion for helping patients achieve optimal health. After graduating from the National University of Health Sciences, Dr. Keller relocated her practice from the suburbs of Chicago to Corpus Christi, Texas. With a unique approach that integrates her expertise in pediatric motor development, chiropractic care, and acupuncture, Dr. Keller is dedicated to guiding her patients in understanding the vital connection between their airway and pelvic floor health. We're excited to have her bring her knowledge and experience to the community. Thank you very much for accepting our invitation. I'm Ann Blau. I'm on the board of Airway Circle, and I'm so pleased to be able to host you today. So if you'd like to share your slides, please do, and I can help field questions as they come in. Maybe we'll have some time at the end for a little bit of Q&A.
All right. Thank you for having me. And does that show up now?
Yes, it does. Looks perfect.
Woo-hoo. All right. So from airway to pelvic floor, untying the connections. A lot of times we think about pelvic floor and we think about airway and we don't make a connection between the two. So I wanted to step back and see about what the physical and anatomical connections are. So we have a couple. From the neurological standpoint, we have the central nervous system and the sensory motor network. We have proprioception, or where we are in space. We have something called interlimb neural coupling, and then perceived threat response. And we're going to go through all of these throughout the slides. But then structurally, we have intra-abdominal pressure. How do we manage the pressure within our system? A lot of times in the airway health, we focus from like diaphragm to nose, but in the PT chiropractic realm, we focus more on diaphragm to pelvic floor. So I like to bring them together so that we get that full picture. And then I like the acupuncture sinews and Tom Meyer's anatomy train just to show how those interact with each other. And then postural stability, which comes from the work of Paul Hodges. Just to show you different ways you can modify the body to make things more effective on both ends. Whether you're a therapist or an airway specialist, things you can do in office to help your patient or know when to refer, where you're like, oh, I never thought to ask this, so let's see it. So the main goals of this is just to discuss the connections, demonstrate a couple of exercises, because I'm very movement-based in practice and just in my home life where I like to be constantly moving. So I'd like people to be tactile and understand and feel it so that they can retain that information better. And then just discuss the importance of co-management of pelvic floor and airway, because I really think for our patients, we can't focus on one. We need to have everybody else involved so that they can get the best care and best improvements. So first, the neurology component. And I put facts because a lot of times it's like, well, are they connected? So first, just pain. And I found all of these just to show that there is a lot of overlap. 78% of women with vulvar vestibulitis, which is severe pain and inflammation at the vaginal entry. The vestibule is where a lot of people just call it the vagina, but the actual opening is the vestibule. But 78% of people that have severe pain and inflammation at that opening also have orofacial pain. 66% of women with vestibulodynia, which means just inflammation and pain in that area, also have orofacial pain. IBS patients are 3 times more likely to have temporomandibular joint dysfunction than non-IBS patients. And then people with pelvic floor dysfunction are 94.6% more likely to have TMJ dysfunction. And this is actually where I kind of started into the airway, where I had I'll say dabbled in Airway when my first child was born and we had a lot going on. And then I was like, women are so underutilized and under-supported in pelvic floor. So I went to the pelvic floor realm. And then I was like, we know nothing about potty training and all of that aspect of pelvic floor. So I went into the pediatric pelvic floor. And then once I learned about pediatric pelvic floor, I was like, what am I missing? And it brought me back into the Airway component. So it was a lot of things going into this nice little circle of, you can't have motor development of the pelvic floor without motor development of the Airway, and without development of the Airway. So that's what brought me into this realm, was a nice little circle in life that brought everything together. Something I've heard frequently in the myofunctional world is, what you see in the body is what you get in the mouth. I'm not a person to just accept statements as fact. So I'm like, but why? And reference number 5, there's a large reference thing at the end. But there was a graph that I was like, okay, this finally makes sense as to what we're seeing in the mouth is happening in the body, and vice versa. We have the cerebral cortex, and I promise this is the heaviest portion of this. But we have the motor control and the somatosensory control, including proprioception, so where we are in space. We have the limbic system, which brings us home, which is homeostasis, olfactory, memory, emotion. And emotion is extremely important with this, but it also modulates our ability to know when we're full, acid production in reflux, and as well as the ability to regulate and respirate through balance of partial pressures of oxygen. So even the act of breathing naturally influences our acid production and reflux. So all of those are interrelated with the limbic system. And specifically the basal ganglia we think about coordinates those fine-tuned movements that we often see, including in the mouth. We have the thalamus, which I'm going to highlight as more of the processing emotions, and specifically fear and anxiety, and how those impact both here and the pelvic floor. And then we have the brainstem. And one of the things that I found most interesting is that the pons specifically is the mastication center. It controls chewing, it controls swallowing, it controls that coordinated movement. It also is where we control micturition, or the ability to urinate and defecate. So the same area of the brainstem controls chewing and eating as it does the ability to urinate and defecate. And it also manages proprioception, again, where we are in space. The cerebellum is more the balance, coordination, and ability to use the muscles, or the sensory ganglia is more bringing it all together so that we can feel those things and bring all the senses in, up to the brainstem, into the thalamus, connecting the thalamus and the limbic system into our ability to fine-tune movements through that limbic system. All of that to go into the homunculus and proprioception. The homunculus is a really cool thing. Basically depicts where information is processed in our brain. We have a sensory and we have a motor homunculus. I specifically pulled out the sensory because proprioception is our internal sense to tell us where we are in space. And the TMJ has the most proprioception per joint, and the tongue has the most proprioception per surface area. So when we think about being grounded in meditation, if somebody's tongue is hanging down at the floor of their mouth, they're not going to be able to ground themselves. If somebody has a tight pelvic floor, and they're just constantly on guard, and even as I just tightened my pelvic floor, you probably saw my chest lift and go into that more anxious breathing mode. But as we do that, we want to incorporate proprioception into not only the oral component, but the pelvic floor component. So a lot of times in office, I'm going to backtrack for a minute because I just decided to. In office, when I'm working on pelvic floor patients, I constantly remind them, tongue gently on the roof of the mouth, lips closed, because otherwise you see, say, do a Kegel and you'll see them like clenching their jaw, open mouth. They're so focused on the pelvic floor that they're not able to relax this. And I can't get them to relax their pelvic floor if their airway is tight and if their TMJ is tight. So in the pelvic floor aspect, I focus on what is your mouth doing when we're doing this exercise. Equally, when we're working on airway, and I will co-manage with my favorite SLPs and OTs and myofunctional therapists. But I always ask their permission, I will say this, but we often tweak exercises. So if they're doing tongue caves, but as they do a tongue cave, I'm watching their body just kind of wiggle as they're like, I'm doing a cave, and they can't get comfortable. We increase other bases of support. So putting their hands open onto the counter that they're sitting next to, feet planted on the ground. Oh, I am making facial expressions because I talk with a lot of animation. So I'm sorry. I don't know how to show me as well.
Yeah, we were trying to troubleshoot this. I'm not sure we had lost her video. Otherwise, we couldn't get this screen to share. So the only other way I could think of you being able to show your video, Dr. Keller, is if you use the same login and log in from like another device. And
I can try that and then just
yeah,
please
just
let
to
me
have
know if
your
it screeches.
yeah, I would just mute yourself on that other device, but then at least I don't know if you like have a phone, you could even like mount it so it's just you can just see your face. Because I know
Yeah.
you are trying to demonstrate. No, that's okay, Laura. I was thank you for saying that. I was trying to figure out a good way to interject without interrupting you.
No, I appreciate that. It just came up on my end. And I'm gonna make sure I'm
Recording in progress.
Okay, we see you now. I just don't. Are you gonna have to hold a device the whole time to do that?
I have a water bottle that
Oh.
I think can
So we are, something is echoing, so I don't know. You are muted, so I'm not sure why. Try talking now. Something is still echoing, so I'm not sure what it's picking up.
let me, if I maybe mute my phone.
Oh, let's see. Talk now. That might have
Does
gotten a
that,
little bit better.
I just muted my phone. Does that sound better?
That sounds good. Yeah. Mhm.
Okay. And then I, for some reason, can't see myself. Um,
You still can't see yourself?
participants.
If
I
you're on your
can't see
phone on
myself, but
Zoom,
can you see enough of me?
Yeah, we see you now. Yes, we do.
Okay. If that works for you, I'm okay. And if you're like, this doesn't make sense, just let me know.
No, that does work.
Okay. So going back to if you are working on like oral motor stuff, sometimes just adding hands on a table or even having them put their hands together can increase that proprioception so that they know where they are in space. Feet flat on the ground. I don't know if you can see me. I don't sit feet flat on the ground almost ever, but that goes into like the hypermobility portion. So you need to meet the patients where they're at as well. I included the 3 pictures because these are the ones I do most often with my co-management patients, where if you're on the oromotor side, you may be doing the tongue caves. And if somebody is kind of all over the place, you can say, hey, let's do tummy time. And you can do tummy time with them and have their hands up so that they're uprighting, and then do tongue cave and tongue clicks and do the oral motor work so that they can get more support through their abdomen, through their pelvis, through their hands, even through their feet. Or you can have them go back and lay down on the floor and you can just have them lay flat. If you see that they're like arching their neck up, then just give them a little rolled up hand towel behind their neck to support them, because we want the airway here to be lined up with the diaphragm, and then the diaphragm to be lined up with the pelvic floor. So we want all of those.
I'm sorry to
in the
interrupt.
relative
Your
Yeah.
phone must have slipped. We lost your view again.
Of course. So, is that better?
No, it looks like we're seeing, yeah, whatever that thing is that you just, there we go. Okay, that's better.
You saw my chair with my dirty laundry. Awesome.
No,
Uh,
it was just black. It was just black. That's all we could see, just black.
can you see me now?
Yes. Say that point one more time if you don't mind.
What?
Can you say that last point one more time if you don't mind, what you were explaining about the
Yeah.
position?
So you can do tummy time, getting upright and making sure that they just are lower abdomen on the floor, pubic bone on the floor, legs back or arched up. If they are hypermobile, or if you see them jutting their chin, so you have them lay on the ground like the second and third picture, you can prop their legs up on a chair. But if you see their head going like this, where they're going into that airway, like I'm trying to get more airway open and I'm just
Yeah.
naturally tilting my head up to get it, we want to bolster that. We want to lift the head just a little bit. And this actually tells us how somebody's improving. If they need a lot of bolstering at the beginning, and then as you improve the airway, you're like, oh, we don't need to use a rolled up hand towel as much. Like we can use it less, to the point that they can lay flat and they aren't grinding their teeth or doing that neck chin up to try and get more air. That's a great sign of improvement.
Okay.
Uh,
Whoever is not seeing Dr. Keller, I think everyone should. You may not be seeing all the
Am I
participants.
in the chat section?
If you, yeah, if you go into side by side gallery, you should see Dr. Keller. I can at least. Is everyone else able to see her? Anyone else able to just respond in the chat? If you have a view of her, I do. Laura, I don't know if you're able to respond. Are you able to see Dr. Keller? Oh, she doesn't either? That's so strange. Okay. I wonder, okay. I don't know how to switch. Because I think this is set in the viewing mode. I think it maybe the view. Let me see something. Can you see her now? You have to talk maybe.
Oh, hi.
Because I can spotlight you, but I don't know. Let me just see something. How about now? Can you still see her slides? Can you see the slides still, Laura?
Can
They see you. Can you still see the slides on the screen? Okay, so I think we're good. Sorry, everybody. All right, I'm not on the screen, but who cares? Okay, go ahead, Dr. Keller. It's all good.
Sorry, guys.
No, this is perfect. I think what you're showing is more important and critical, and I hope we can circle back to that hypermobile part that you mentioned, because
Yeah.
that comes up quite a bit. So thank you.
So
Thank you for that. My apologies.
yeah, I'm actually going to show you, which is going to be more entertaining. So give me just a second. Um, so people that are hypermobile need a larger baseline of support, and myself included. And I think one of the best things I did before having my own pregnancy was a lot of stability work. But a lot of times we are doing the mouth work. We see people that are kind of like, jaw might be moving, they might be fidgeting all over the place. So putting them in different positions. And that includes going on to, my feet are flat on the floor, but I just want you to be able to see my neck. So oftentimes you'll see people that do this movement. When as soon as they lay down, they go into that airway protective mode, where they're trying to get that mandible lifted. They're trying to get more airway space so that they can breathe easier. So we don't want to take that away ever. So I want to bring that back by just supporting it. So we can just do a roll of towel behind it so that this is relaxed. Or you can do a little bit higher up. It doesn't matter, but then you can do tongue caves and clicks and do the oral work. Or you can have them go onto their tummy and you can do quite literally tummy time with them. because that uprighting helps with the cervical spine. It helps open this up. It helps them rotate, which helps with breathing. And then you can have them in this position with hands open to increase that proprioception so that they can get focused more here and they don't have to focus as much on where their body is.
Okay, that's helpful. So that's a little bit like, I guess if you would use, that's like the Sphinx pose in yoga a little bit.
Yep.
Okay, perfect. Thank
Yeah,
you for demonstrating that.
the
That's
biggest thing we don't want is them to like dip into the low back where it's like excessive arching.
helpful.
But other than that, yes, like Sphinx pose, we're not trying to get that mid low back stretch is the one thing I would say we want to make sure of.
Okay.
Yeah.
Thank
So why is this important for the pelvic floor? So proprioceptive training plus pelvic floor stimulation is more effective than pelvic floor stimulation alone. So when we add proprioceptive training into the pelvic floor aspect, we can improve muscular strength, which that is basically like the ability to do a Kegel. We can improve endurance, which is like the ability to go on a run and not leak, improve repetitive and rapid contraction ability. This is more like upper respiratory infections. Can you do enough Kegels or pelvic floor lifts? And I don't actually love Kegels, but can you lift enough to support if you're coughing or sneezing repetition after like time after time? It can increase vaginal wall elevation and increase the lower tone. So a lot of like specifically moms have that lower abdomen that doesn't get tight. So when we increase proprioception, we can increase the ability of the lower abs to contract. And that can be either through the tongue, or if you're working on oral motor, you can work on hands and pubic bone strike in order to get that information into the brain. So by increasing tongue and TMJ proprioception, or ability to know where you're in space, we can increase the overall sense of where the body is, improve postural control, stability, gait, balance, and all of that, so that we are improving how the person is able to stand. So this next part, I'm also going to move, but I'm going to have to move my water bottle. Spinal accessory nerve glide for hip rotation and pelvic floor. You might be thinking, why did she include the neck and nose breathing versus mouth breathing? So women with lower tract urinary symptoms had weaker hip external rotation and abductor muscles, but similar pelvic floor strength and endurance. So what research tells us is it's not strictly pelvic floor. It's also the ability for the hips to rotate. And we have strengthening pelvic floor hip muscles and hip synergists improve frequency of daily urine loss. So I included this because we're going to do an exercise for movement rev is where I learned this from, but it's a spinal accessory nerve glide. And I'm going to go back to over here. And we're going to go a slide forward. So this is you can do this a couple of ways, but for the spinal accessory, we can see like, how do our shoulders move? And if you have time and you're comfortable doing this at home, like truly see like, do my shoulders move freely? Like my right shoulder gets a little bit of a hinge. You can also do hip. So how easy do your hips move, knees in, feet out? And you can see which way is stuck or movement, free of movement. And then I'm going to come a little bit closer. And we want to work the spinal accessory nerve, and we'll go back as to the why. But for this, you want to act as if you're a marionette doll getting pulled up and elevated and elongated. And then you put your arm out and you just retract, pull the arm down a little bit, and you can have your wrist extended like that. And then I want you to, still elongated, turn the head and neck, and then shut your chin out a little bit, and then just nod 5 to 6 times. If you have tension in the arm, it should only at most go up to a 3 or 4. We don't want to be barreling through pain because that means that we have more of a nerve issue and we want to address that. But we just do a couple of head nods and then we come back and we see, how is my shoulder? My shoulder admittedly doesn't change, but what always changes for me is my hip range of motion. So that tells me that my hip range of motion is more of a diaphragm issue and more so and spinal accessory upper cervical issue. So we can decide, is this a pelvic floor issue or is this a spinal accessory issue? And that is why I posed the picture of the open mouth breathing, because a lot of times people that have that forward head posture and that movement, they end up having pelvic floor pain, but it's also, we can work here in order to help the pelvic floor. And I think that's important sometimes when you just go to talk to another provider, where you're like, hey, your patients that are struggling to get better, if you're talking to a pelvic floor PT or OT, or chiropractor like myself, like, I can help with this component so that your patients get better results. I can help them put their tongue to the roof of the mouth gently so they're not just grinding their teeth trying to find that stability. But you can have them show them that, hey, I can work here in order to support here while you're also doing strength exercises. And reverse, like the pelvic floor PTs need to know, if I have somebody that's not getting better, and I can look to an OMT to do the work so that they can get this. So it's all about that coordination and knowing when to refer, because if somebody has that chronic hip pain, but they keep working on the hips, they're working on the low back and it's still not improving, it's usually because it's not a low back or a hip pain or a pelvic floor issue. It's an airway issue that is coming up, or a neck issue that is coming up and referring down. So I think that's really important, just to know when to refer and how to see those patients that might have improvement. And like shoulder issues, largely, unless there was a traumatic injury, shoulder issues are a diaphragm issue. They're a breathing issue, not a true shoulder issue. So I'd like to just make sure that when you're looking at the person, we can step back and say, hey, is this a pelvic floor issue, or is this an airway that has now become a pelvic floor issue? And I think that's just important to know. And because I'm a Y person, I included all of the nerves that are in the neck at that region at Erb's point, which intervenes with the spinal accessory. But the most important part is that the spinal accessory comes from two parts: the cranial portion, which connects with the vagus nerve, and the cervicranial nerves C1 through C5 and 6. The phrenic nerve, which is the main nerve for the diaphragm, is at C3 through C5. So they very much talk in this region, in this neck, which is also where the hyoid happens to be. So if we are working on the hyoid and we're working on the SCMs in order to release that spinal accessory nerve, we can heavily influence what's happening in the pelvic floor. So I'm going to go back one more. So going back into hip rotators and abductors is similar to a tongue tie, where if you're not able to get the movement, you're never going to have full range of motion. And if your body is inhibiting from up here in your cervical spine, if your body's saying it's not safe to move into those hip positions, or we're using that stability elsewhere, then your body, you can retrain it. So we want to get the range of motion by working on the neck and the breathing component so that we can get the hip range of motion so that the pelvic floor exercises are more effective. Any questions on that?
I'm digesting it all. Thank you. This is great. We've thought of it this way, but I think it's still a little bit of a different way of really thinking, because it's bi-directional, obviously.
Yeah, it's bi-directional.
Yeah.
It's not a one-way street ever. And then we have opposing joints or interlimb neural coupling. Opposing joints is easier to tell people. Interlimb neural coupling is what it's referred to in research. Sorry about that. We are having fires down here and 45-mile-per-hour wind with a drought. So my allergies and everything are acting up more. But opposing joints is the movement of one limb interacts with the movement of another. So we can improve range of motion and strength while decreasing pain by working on the coordinating limb. So specifically, the two you probably are most interested in is to improve the right TMJ, you can work on the left side of the tailbone. To improve left neck pain, you can work on the right pelvis, and vice versa. And this is newer research in the last like 20 to 25 years, but equally, it's something that traditional Chinese medicine has said since the beginning of time, where it's well known that in order to treat the left shoulder, you treat the hip or you treat the opposite side. And a lot of that goes back to the brain information where 80% may go to the same side, but 20% still going to the other. So if you're having trouble on this side and it may be protective, you can work distal and you can work on getting those other areas moving and relaxed in order to relax the area you're working on. So if somebody's having constant right TMJ issues, or they're not able to get the left neck to really relax, you can send them for referral to work lower and see if that turns around and improves the other area. So just knowing that if something isn't improving, the question is always why. What's happening? What is preventing it from happening? And what can we do to change that neurologically so that our body accepts the movement that we want to go to? And then because, again, I'm a why person and a show me the facts, a single session of TMJ soft tissue therapy for temporalis, masseter, and pterygoid relaxation can decrease resting tone of pelvic floor in hypertonic patients. This, I'm going to backtrack just a little bit. A lot of times we've been told Kegel, Kegel, Kegel for anything pelvic floor related. Incontinence, Kegel. Pain, Kegel. But a good chunk of patients are actually hypertonic. You can think of it as they're trying, like the pelvic floor should move up and down. If a person is rigid or tight, they're basically jumping on a trampoline with stiff legs. So they're never going to get that full contraction because their body isn't able to relax and go into that full range of motion so that they can get the full contraction. So by decreasing the resting tone, we're allowing that muscle to freely move in its full range of motion so that we can fully strengthen it. So working on the TMJ also results in an almost 19% increase in pelvic floor activation. I will say this wasn't statistically significant, but I don't, this is where I'm research aware and evidence-based aware rather than evidence-based solid practice, because if somebody's having a hard time activating their pelvic floor, I can't get them to relax or activate at all, I'm not going to restrict myself from not working on the TMJ because it says it's only an 18% increase. I'm going to do it once or twice and see if it helps that specific patient, because not all patients are the same. And if it's an improvement but not statistically significant, it's something that I'm going to have an open conversation with the patient and say, hey, we can try this. It's not fully supported. It has no harm. So can we try this once or twice? And if we don't get improvement, we'll go elsewhere and try something else. But oftentimes they're like, yeah, I want to see improvement. I don't care. And they know that I'm telling them like 1 to 2 visits. We're not going to do this for 6 to 8 weeks. We're just going to see, do they find improvement worth working on the opposing joints, and then go from there. Next, perceived threat. And this is probably one of the most important things I can talk about, because we often think like TMJ, awake bruxism, it's strictly fear, or it's not strictly, but oftentimes it's like, where are your stressors? What are your fears? Where are your anxieties? Perceived threat can cause pelvic floor activation in vaginismus patients, which is more full vaginal pain. So pain with penetration, things like that. And awake bruxism, so grinding while awake. So this goes back to that thalamus, and fear and anxiety influence how our body responds and those fine movements that we have. So why is this important? This is one of the most important things I can say, because we do breathing exercises. And I am an absolute lover of breathing exercises, both from an oral motor standpoint, an airway standpoint, a diaphragm, a ability to stabilize the low back and abdomen and pelvic floor, as well as like constipation and pelvic pain. Like all of that improves with breathing exercises for most people. In the rare case we have somebody where breathing exercises don't yet feel safe. And this can be from stress. Oxygen Advantage discusses beautifully like the air hunger aspect and how that might scare somebody. Anxiety. And anxiety, I will say this often comes with my neurodivergent people, including the altered interoception, which is later on. Because, and I say this as a neurodivergent person, sometimes being present in your body with a breath exercise doesn't feel safe, because for the longest time since we were young, it was never safe to be present and calm. So we are so used to being all over the place that coming down and getting into that calm space and going into that parasympathetic state that our body isn't used to can be terrifying. So if you ever have a patient who tells you they don't like breathing exercises, I think it's really important to say, like, okay, do you know why? And sometimes it's the air hunger, and sometimes it's anxiety, and sometimes they're hypermobile and they've been told to like take a deep breath. So they're like, and really we want like as a breath. It should be soft, it should be quiet, it should be gentle, but they're told to like big belly, big breath. So they're used to sucking in and blowing their belly out as far as possible, which is now causing more stress because now their nerves are like, what? We're tightening? And then even the social aspect of sucking in, especially women, where it's like, okay, like make sure you look good for a picture. And to let it all hang out in order to get a full 360 diaphragmatic breath where your ribs are expanding here, your pelvic floor is expanding, your low back's expanding, it can go against everything we've been socially taught. So that can be really difficult. Also, anemia, trauma, that can be emotional or physical. So I think that this is really important just because we can't assume that something as awesome and beneficial as breathing exercises is awesome and beneficial for everyone. And sometimes we accidentally cause more pelvic floor activation and more bruxism by doing those exercises because they aren't safe yet. So this is something we can work on, but it's not there for them at this moment.
That resonates with me a lot because I actually have a hypermobile patient right now, an adult, who was recently diagnosed with pectus excavatum, which is kind of interesting because you think she's so hypermobile, but now she's sort of restricted by that. But when we've tried a lot of exercises, I think humming might be the one that's maybe the safest, but she experiences dissociation whenever we do exercise very, very early on. And she's someone I'm trying to kind of figure out what the right bodywork professional is, but we're just sort of struggling with a lot of things. And so this is really, and I feel like in all the things I'm thinking now, like more about like the pelvic floor and how that is responding to this too.
Yeah, and it might not be what body work as much as what body work provider. Where if she doesn't feel safe, she needs a person that she can connect with so that she can let them in enough to do it.
Agreed. I had sent her to an osteopath who specialized in hypermobility, and we spoke about it after a lot of the treatments, and she just wasn't feeling like it's right. And you know how it is. You could send the best provider if it's not, if it's not the right match. And so she saw someone else who has a different approach, more like a dynamic neuromuscular rehabilitation approach, and she'd really like to try that. And I said, it's all about who you feel comfortable enough to help you and to be vulnerable with. So yes, agreed. Thank you.
Yes. Yeah. And then informed consent prior to treatment. I am having previously worked in like birth, this is where I'm a stickler that we tend to just ignore informed consent, where it's like, oh yeah, you gave me permission to do everything. Um, but I like to be upfront where I'm like, hey, this sometimes happens. I want you to know that you're not alone, and I still want your permission. If you feel it, if you feel discomfortable at any time, like you don't, even if you don't feel like telling me, you can stop it. You can stop the breathing exercises. You can just be like, nope. But letting them know beforehand if something doesn't feel right with them, that they can stop in that moment and we can find something else or try to do different things. And you'll find some people are like, okay, I just need to feel a different position, or I need to like be a little bit more present before I can do it. But giving them that autonomy to stop and knowing that it's okay for them to stop is huge. But, so next, sleep disordered breathing. And I apparently got really overly excited with the graph on sleep disordered breathing. So sleep disordered breathing increases constipation. Constipation increases bedwetting. Sleep disordered breathing often increases reflux, which is often related to enuresis. It changes intra-abdominal pressure. It doesn't allow us to get full antidiuretic hormone. So at night, our bladder should be more concentrated because the hormone is released and we're like, okay, we don't need to dilute it basically. We can have a little bit more concentration so that we can hold it until through the night until morning. So when that doesn't happen, because we're having the constant wake ups, that's when enuresis happens. So a lot of times we like to think it's just one thing, and it's actually all of these things interacting that can cause enuresis. So I don't treat bedwetting alone. As somebody that does pelvic floor and airway, I always bring somebody else in. Why does sleep disordered breathing? You're basically in fight or flight. So you're never able to go into rest, digest, bowel movement. So sleep disordered breathing is basically your body's constantly on high alert, which then slows motility. So instead of the smooth muscles in the intestines, like going nice rhythmic motion for peristalsis, it ends up slowing that digestion. So it's like, so it's not that nice fluid movement that allows peristalsis to go throughout the throughout the large and small intestine to go to the rectum. It slows that motility and mobility so that it increases the constipation.
Can I interrupt? Sorry, before you go on, because I don't want you to have to like circle all the way back. I'll just ask a quick question. So, for example, you can do all the vagus nerve stimulation exercises you want. That wouldn't necessarily help get you into enough of a parasympathetic state to change that constitutional constipation if that is coming from sleep disordered breathing. Is that
It
correct?
depends on the person.
Okay.
So some, yeah, vagus nerve is enough. You can think of it as like a sensory cup or a cup where it depends how much the person is getting depleted elsewhere. So is it just sleep disorder or is it just vagus nerve? But if somebody is going through like drastic life changes, divorce, moving, new kids, adding kids, things like that, it vagus nerve alone isn't going to do it. Like you have the emotional bucket, you have the sensory bucket, like are they getting enough sensation? Are they moving enough? You have the sleep component. So there's a lot that goes into the parasympathetic and sympathetic and emotional regulation that isn't just vagus nerve. It's, are you getting enough exercise? Are you getting enough sleep? If you're not getting enough sleep, you're not getting that. It literally slows digestion, which means you may not be absorbing enough, or you may be absorbing stuff that you don't necessarily want to, or you're constipated now, and that constipation, nobody feels good when they're constipated. So now you're having more stressors because of the constipation. Um, so it, and even going into sensory, like, do you need yoga, or do you need like the calming movement, or do you need more of like the high intensity to meet your sensory needs? So it's a bucket full of life where it's all the stressors coming in And vagus nerve is one way to let that out, but so is exercise, so is sleep hygiene, so is the myofunctional, so is making sure the sleep disordered breathing is improved. So it's not just one thing. Sometimes it is. Don't quote me that it's never. But rarely is it just vagus nerve stimulation that's going to help, or just taking care of the sleep disordered breathing if there's other stressors that are still coming into the life causing that fight or flight.
That makes sense. Thank you.
So I think a lot of people already know, like, enuresis is associated with obstructive sleep apnea. I feel like this is actually better known in the myofunctional realm than the pelvic floor realm. In pelvic floor, it's just been in the last 2 years where people are like, oh, we might want to check that. And it's frequently women that are overlooked, because it's like, oh, you have kids. Of course you wake up at night to pee. But I'm always like, okay, are you waking up because the child is crying, or are you waking up and then having to go to the bathroom? There's a difference in those, where you're waking up because the kids need you, and you're waking up because you have to use the restroom. So those commonly go overlooked, especially in people with young children, just because it's, of course you're waking up to pee, like you have kids. Where we notice it more so in men, because we think, oh, it's either sleep apnea or prostate issues. But in women, it's, you have kids. So we're just going to ignore them. So nighttime waking is more commonly overlooked in women, because we just associate it with other things. So I just want to highlight, like, if you have a woman that is waking frequently and using the restroom, sometimes she'll be like, well, I'm up, so then I go. But we want to retrain the brain and the bladder that it doesn't need to wake up. And we want to make sure that sleep disordered breathing isn't one of the causes of that. Structural. This is one of the funnest. So nose breathing, mouth breathing, we already saw this graph a little bit, but now I want to tie it into, this is something I think every myofunctional program discusses, the mouth breathing forward head carriage. So this is where we bring the oral motor working on the front half, from like airway, nose to diaphragm, and then diaphragm to pelvic floor. The diaphragm is where the upper cross of Yanda meets the lower cross. So we see this aspect, but in my realm, we then see what's going on here, what's going on with the abdomen and the diaphragm, what's going on with the pelvic floor. So the diaphragm isn't just for breathing, but it's also for joint centration, core stabilization, movement awareness, and quality of support. So we want to work on not just the diaphragm, but being aware of what's happening down here that may impact up here. Mary Mastery is at least the only one, to my knowledge, and she was definitely one of the first to look at the breath from the larynx down. So she looks at larynx, diaphragm, and pelvic floor work in a coordinated manner. So as everything moves down, I want you guys to think about, what's happening up here, but what's going on down here? Yeah, Mary's wonderful. So during inhalation, the pelvic floor literally descends. This is, going back to perceived threat, this can be frightening for some, because even a normal range of motion can be intimidating if you're expecting incontinence or pain with that movement. But the ability to breathe into the pelvic floor and let it relax and drop down a little bit is an eccentric contraction. This is when we build muscle mass, so that stability and that strength component. And then the exhalation is what people commonly think of when they think of Kegels, of the pelvic floor ascending, creating the concentric contraction for power, strength, and explosiveness. The ability to respond if you're doing jumping jacks or jumping rope or coughing. It's the ability of the pelvic floor to go through the full range of motion, and that is 100% dependent on the ability for us to breathe. So I'm actually going to jump once more. So I want you guys to feel this. So if you're comfortable with it, again, if you are not, feel free to excuse yourself from the exercise, but I want you to just do a brief pelvic floor scan. Can you even feel it? Like, are you aware of what's going on down there? Now just take a gentle inhale and note how your pelvic floor feels. Were you able, if you're sitting on your sits bones or you're sitting on your butt, can you feel your butt expand? Can you feel your lower abdomen right inside the ASISs right here? Can you feel that widen and open? Can our lower ribs, when we breathe out, do they open like this and kind of widen? So I want you to just feel that, but specifically feel the pelvic floor. And then exhale. And just notice what you feel. Can you feel your pelvic floor relax and lift? After that, I can't do it easily while explaining it, but I want you to place your thumb just on the median palatine suture, apply gentle pressure with the tongue. You can do a little suck and repeat the exercise. Oftentimes, if I have patients that I can't get pelvic floor changes in, I will have them do a quick suck of the thumb and then do a Kegel, which is like lifting a blueberry or a feather in your perineum. It's a very gentle lift, or it can just be what your pelvic floor naturally does with an exhale, but feeling that sensation. So I like people, even in myofunctional realm, to know that this impacts it, because if somebody is constantly tightening their tongue and they're like, must think about tongue to roof of mouth, must think about tongue to roof of the mouth, they're not doing a nice gentle hold. They're going to be, which may also change how their pelvic floor responds. So if you have somebody with pelvic floor pain, which ideally this is in your intake as well, you can double check, like, hey, as we're doing our tongue caves, how's your pelvic floor feeling? If it's feeling okay and they're like, no increased tightness, or if they're like, I am starting to feel really tense down there, then it's important to have them relax that. And we need to find a happy medium to balance the improvement we're finding here without increasing pain and sensation here. So it's making sure that we're aware of those connections, so that if somebody is, maybe they're able to get the tongue on the roof of their mouth now, but now they're tightening their pelvic floor, we don't want to accidentally increase pain and compensation elsewhere down the line. So that's just an important thing while you're doing it, is making sure that while your focus is here, if they have pain in the pelvic floor specifically, hey, let's make sure that this breathing exercise doesn't improve that. Let me know if anything goes on. And if it continually does, that's where co-management is extremely important, because we want somebody that can check in on the pelvic floor and teach them to relax that and focus on a breath that is calming and relaxing for the pelvic floor, so that it can get that full range of motion. And then we can come back and coordinate it with the oral motor portion. And then this goes also into the interconnections that we often don't think about. But I was trained in acupuncture before I graduated chiropractic school even. So I like the TCM approach, traditional Chinese medicine, and the energetics of the stomach channel. So the stomach channel treats anything from face, cheeks, lips, gums, ears, throats, and digestion, and ripening of food, and descending of qi, which descending of qi includes the breath as well as the food. So if our stomach channel isn't able to descend, it's not able to properly pull in the breath in order to disperse it throughout the body. So this goes into somebody that has like chronic upper gum, supraclavicular pain, difficulty breathing through the chest, and then pain or discomfort into the anterior pelvic floor and the legs. So this is just another approach that if you're like, nothing's working bodywork wise, or they are a highly stressed person, many of my type A people or neurodivergent people respond better to acupuncture first to calm the system, so that then they can come in and work on the oral motor component and relax the system enough to do it. And then going into, I debated going where this is. So constipation, oral motor dysfunction. Children who experience functional constipation have aberrant oral habits, which are considered indirect indicators of psychological stress, such as lip sucking, finger sucking, and nail biting. And I think it's important to know who does the research, because none of these people are trained in oral motor. None of these people are trained in oral facial. None of these people are trained in breathing up here. And they looked at oral habits and said, oh, it's strictly psychological stress. And it may be that that's their stim, but we want to look at why. Why isn't the tongue on the roof of the mouth getting that information into the system? So they left out the oral motor function and the ability to use the tongue to stabilize the body. They kind of don't know about that proprioceptive perceptive input from the tongue and TMJ that also help regulate the system to do it. They blame it all on stress for constipation when it's equally what's going on here. And you asked about constipation earlier with sleep disordered breathing, but I'm going to go into it just a little bit more. If we break down oral motor function and its role in digestion, even the ability of the tongue to go out and move to stimulate the glands so that we can release digestive enzymes starts in the mouth. So how many of our kids don't chew food and they just are like the gulpers? Because chewing food takes a lot of energy. And how many adults as well? How many people can't lateralize the tongue? How many people are just, I chew 5 times and then swallow? So if they're chewing 5 times, of course they're going to have undigested food in their stool. Of course their body is going to be like, hey, we have to slow down this stool because we have to break it down even more because we skipped the entire process of the manual chewing process, the lateral chewing, and we didn't take care of the digestive juices to start the breakdown of foods. So we're going to have to do more work down here in order for the digestive process to work. And then even the swallow is related to the activation of peristalsis. So instead of like the smaller boluses, if they're taking large chunks of food and just chucking it in their mouth and swallowing it, they're not getting those low level of stimulations to create that peristalsis or that movement of digestive process that moves the food along within the system. So they're not getting that breakdown. And then their colon and their large intestine and small intestine are going to have to work harder. Their stomach's going to have to work harder. It's going to have to produce more acid in order to break down all of the foods. And then we're going to have to slow down the digestive process to pull out what we actually need and want because we never broke it down in the mouth. So an interesting fact, when we work on 10 minutes of diaphragmatic breathing exercises, you can improve constipation in kids. And I also think if we work on the oral motor component, that increases decreases the constipation as well, because they're able to break down and fully utilize all aspects of digestion rather than just the stomach and colon. So breathing, there was one that said that the kidney can move almost half an inch with every breath. So when we take a deep diaphragmatic breath, it can also help with that peristalsis or that free flow of the colon to be able to push food through the digestive system. So constipation and oral motor dysfunction are related, but so is that breathing aspect where we need to work on all aspects and the psychological stress of going into rest, digest, and bowel and bladder. So breathing is that intersection that helps with all of those, and the oral motor component helps too. And I should have left that earlier on, and I'm sorry I didn't. So we're going to go back to the structural component, more joint centration and core stabilization. When the diaphragm and pelvic floor are aligned here to here, it's easier to align the glottis and diaphragm to allow the full range of motion and full breath. So a lot of times you probably see this position that I kind of sunk into, and I'm going to go a little bit more like and then you're working on breathing and they're not getting a full diaphragmatic breath. One little thing you can do is to visualize your sits bones. The sits bones are the bony parts of the butt. So like if you were to sit on your hands, you feel that bony structure. We want to kind of rock the pelvis back and forth until that bony structure feels like it's sitting almost like it's on a dime. It's the smallest area where you're like, it's just a little bit. The bones are just barely on that section. And then we can sit upright, feet flat on the floor. But if you take a deep breath and you're tucked, you feel like it's kind of all over the place. And then you find that position with the pelvic floor and the those sits bones, and you're able to sit in a more upright position. The breath naturally feels easier to attain. And that includes up here, where you're not getting, the patient may feel like their breath is constantly stuck in their throat, or they feel like it's stuck in their chest. And part of that is because of this crunched up movement or that forward head carriage, where it's changing angles and it's not able to easily align. So we can change joint centration, where we're sitting and how we're sitting, in order to alter the breath and make it easier, and equally make it easier to get the tongue up to that spot because we have centration through here. And that was the movement exercise we just did, where you can rock the pelvis back and forth, feel those ischial tubes, that the bony part, so that it's upright. And then we kind of naturally feel like we are in that better posture. We're not in that slumped over posture. And that allows us to sit upright so that we can get the breath up here. And that's it.
That was
I'm happy.
Sorry, was that?
Yeah, you're good.
No, it's good. I would love these. These are great slides to have. I love all the research too. So I appreciate you including all of that. Thank you. I'd like to know, where does this come from? What population, were they looking at, under what conditions? So this is really helpful. And I think you tied a lot of it in. I'm sure it wasn't tied in that neatly together in a lot of these studies, the application to the work that we do, and really just emphasizing why co-treating is so important, and really learning about when is it time to send to somebody else to take a look at, why am I struggling with, let's say it's a patient of myofunctional therapy, why am I struggling to move forward with this, or why is the patient reporting this is what it feels like when this is what I've been taught it's supposed to feel like. So I think there's so many different aspects of the body, but I've been incorporating it a lot of different movement patterns, and really working on interoception, because there are a lot of patients, and I don't know if it's a societal thing maybe, or a lot of patients are not in touch with their body, what it's doing, what it feels. And I know, some people don't want to go there, but there are others who just don't have that awareness. And I think before you can create change, you need that awareness.
So that goes into, like, neurodivergent population typically struggles more with interoception. So we're realizing a lot of people that were not diagnosed previously, because it was just like, oh, they're just quirky, it's fine. So the interoception portion, where like this is where, like, I love potty training and like the 2 to 4 crowd, because oftentimes, even as early as potty training, it's like we ignore people's responses and their body signals, because it's like, no, all kids in daycare go into need to be potty trained by 3. So we're going to potty train everyone, and we're going to assume that everybody in this 8-month time period is ready to potty train at the exact same time, and they're going to pee at the exact same interval. So we teach people to potty train based off of time and not listening to their body and what their body's saying, where it's like, oh, I have to pee. Well, we're never training them that. We're never training them to listen to their body as early as potty training, because it's, oh, we're putting it on the time rather than what your body and signals are saying.
Right, exactly. Would it be okay? I want to be respectful of your time. Can I just throw in one last question? Okay. This is from Judy. Her 32-year-old niece has paradoxical vocal cord dysfunction. Would an ENT be the first place to start? What would be the next choice, second choice of providers? Well, I'm a speech pathologist. I would say a speech pathologist would be helpful. I'm not sure. I know you mentioned ENT, but where did the diagnosis come from? Was it not from an ENT? That's my question for Judy, but go ahead, Laura. I'll let you answer this.
No, I would say the same. Like, where did that come from? Where did the diagnosis come from?
And we do have patients who will complain of, for example, muscle tension dysphonia, and that is related to, do you see patients sometimes with that? Oh, her allergist came from her allergist. Interesting. Hmm. Okay.
Yeah. I mean, I'd probably go immediately. Well, it depends on where you're at and what your wait lists look like, because I would get on an ENT wait list and see an SLP at the same time.
I agree. I would want confirmation just to you're in
Yeah.
there should be
So
there should be a lot of providers in DC. I would want a confirmation because otherwise you're treating blindly, I think.
yeah. And I just ask where you're at because right now our ENTs have a wait list. I think that's 8 months now.
Wow.
So you're not getting in unless you're driving the 2 to 4 hours to San Antonio, Houston, or Austin. Um, so I would confirmation from an ENT. So get on a wait list for ENT and see an SLP right now or as soon as possible.
And I'm just going to add, Judy, an SLP who specializes in voice therapy. I'll say just
Yes.
because you want someone who has that specialized knowledge.
Yeah.
Um,
And there are a couple other, like, I don't want to strictly restrict to it. Um, there's a PT named Ginger Garner, and she is fantastic. And she does a lot with vocal cords. I think her history started as a musician. And I don't remember if she was a singer, but she does a lot as well with vocal cords. So she might be another just lens to see it through because it's not always, I mean, we each have our own lens that we come to a patient with. So the ENT sees it and then the SLP might see it, but it might also be a PT who's like, hey, I see this within your body. So let's also work on this.
yeah,
So that's
thank you.
another consideration.
I'm going to look her up. Thank you. I don't know that name, so thank you very much. Any final tips on, and I think you've showed us already some of the things we can do with some of the hypermobile patients, but I feel like some of those struggle with a lot of the myofunctional therapy um, exercises and kind of knowing how to moderate. So, what have you found to be helpful, I guess, in your practice as you're working with some of these hypermobile patients?
Yeah. So my practice, I I've studied a lot of dynamic neuromuscular stabilization, DNS. So for a lot of them, I just bring them back into what's called ontogenesis or the developmental positions that we were supposed to have at birth. Um, okay, I'm just gonna fall on the floor more because why not? We're already there once. Why not make it talk? So this is one of those positions that when a baby's born, they basically have two positions. They have on their backs and then they have on their sides, tummy time. So we have that first position just going here. And you can even just have them supported. You can increase that base of support, but oftentimes it's position. So even if you're having this and you're like, okay, we're focusing on feet, my feet flat now, but we're going to focus on the mouth. But you may see them and they're going to go up and it's like you could drive a train under their back. So even just saying, hey, let's put a gentle towel under your back and now just make that flatter. And you'll see them be able to like bring their diaphragm down and make sure that their neck is supported here so they're not doing that position. You might also notice that they are compensating on the sides where it's like they're not comfortable, they're wiggling side to side. Where you can put a weighted blanket or you can put I feel comfortable doing this, and this I'm not sure about your scope of practice, so please check that. But
Okay.
showing people as like a 1 pound weight on their lower abdomen or a weighted blanket can help with grounding so that they then can go into being able to focus. So it's really about increasing the base of support, which it means number of contacts on the floor. It can increase how much contact they have so that they feel more stable. So tummy time, again, going back, you could
Transition that.
What?
How do you transition? Because eventually you want to transition that to upright and seated, right? How do you do that?
So if we're in tummy time, we're here, and then here, And then you can go into this position. If somebody needs more support, assume this is an exercise ball. You can put the exercise ball, and they can push the exercise ball into, I guess this wall would be better, into the wall. And
Okay.
just pretend like they're breathing. And then you can go into like a half kneel position. And then from the half kneel, you can say like, okay, can we do it in a squat position? Again, I am hypermobile. Do not expect this movement from patients. But like, can you do it when you're supported here in a squat position? And then you can go upright, or you can do it seated and make sure that like feet are flat on the floor and they're on the sits bones and they're doing all of those aspects before going into the other.
Okay, that is perfect. Thank you. That really helps me quite a bit because I've got parts of this, but you're helping it all gel and come together. So thank you, thank you, thank you once again. We sorted out the technology, so all is good. I've spotlighted you. So hopefully everyone who watches the recording will be able to see. I'm sure they will appreciate it as much as we all did. So I wish you a speedy recovery. If you are not a member of Airway Circle, please do consider joining us so you get early access to talks like this and can view all other talks in our library. And I don't know if you're in our provider directory, Dr. Keller, but we do have a free provider directory if you'd like to join. And we hope maybe you'll come back and talk to us again. So tell us where your practice is and the name of your practice. Where can we find you?
So I am in Corpus Christi, Texas. And then I do online for only the state of Illinois. So I actually don't know if I updated after I moved last year. So I have to check Airway Circle to see. I think I'm on the directory. I don't know what state I'm listed in. But yeah, so Corpus Christi, Texas.
Okay. And what's the name of your practice?
Dr. Lauren Keller.
Okay, that's easy enough. Thank you. If anyone who is going to be watching this has any patients or clients in Texas, please reach out to Dr. Keller. It sounds like you would be a great resource for us. So thank you very, very much.
Questions? I should have included Dr. Lauren, DRLAUREN at drlaurenkeller.com.
Okay, thank you. I appreciate it. Great, lots of great feedback from some of the participants who are here. Great webinar. This is fascinating. Someone's mentioning she's got to learn more about it. And I think that's what we're all trying to do, just trying to, help our patients the best we can with the resources that we have. And if we don't have those resources, going to seek them out. So thank you, thank you, thank you. It's great to see such airway aware providers who are looking above the neck at what sits on top of it. Sometimes we have, others that look at every other part of the body, but this is still an important piece. So thank you very much. I hope you feel better soon.
Thank you. Thank you for having me.
Of course, my pleasure. Take care, everybody. Have a good day. Bye-bye.
Bye.